Hi, everyone. Welcome to the Lymphoma Research Foundation's Understanding Diagnostic and Biomarker Testing. I'm Jessie Brown, and I'm the Director of Patient Education Programs here at the Lymphoma Research Foundation. During today's webinar, you'll hear from an expert speaker, and you'll have an opportunity to also ask questions. You can ask them at any time in the Q&A box on the bottom of your screen, and we'll address as many as possible as we can in the hour. As a reminder, this session is also being recorded. At the end of the program, you'll be prompted to complete a program evaluation. Please complete this as we do incorporate your feedback into future programming. For now, let's get started. Thank you to each of you for taking the time to join us. Next slide here. We'd like to thank our sponsors of this webinar, Foundation Medicine, Genentech, and Merck. At the Lymphoma Research Foundation, our mission is to realize the promise of science to eradicate lymphoma and serve the community touched by this disease. All our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. In addition to today's program, we have a variety of other programs and services available for you. The Foundation has free comprehensive disease guides, and fact sheets, which could be ordered or downloaded on our website, lymphoma.org. We also offer a variety of other in-person and virtual education programming, so you continue learning about the latest updates throughout the year. As part of our digital resources, we also have an award-winning mobile app called Focus on Lymphoma. The app provides helpful disease content as well as unique tools to help patients better manage their lymphoma. The app is available free of charge in the Apple App Store and in Google Play. In addition, the Foundation offers a wide range of support services. One example is our helpline, which serves to complement our patient education programs as a resource for both patients and care partners. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network. Through the LSN, we can connect patients and care partners with others who have been through similar experiences for emotional support. I would also like to briefly highlight two upcoming in-person programs: our West Coast Lymphoma Workshop, which is a one-day event, which will be held in person in Los Angeles on September 14th, and the Educational Forum, which is a two-day event held in Brooklyn, New York on October 26th and October 27th. Both educational programs will provide latest information about lymphoma, current treatment options, and patient support issues, as well as having disease-specific subtype sessions. You can view the agendas and register for these programs on lymphoma.org/programs. And for now, we have a wonderful program planned for you today, and I'm honored to introduce our speaker, Dr. Marco Ruella. Dr. Ruella is an assistant professor of medicine in the Division of Hematology Oncology and the Center for Cellular Immunotherapies and scientific director of the Lymphoma Program at the Hospital of the University of Pennsylvania. Thank you so much, Dr. Ruella, for speaking at our program today. I will now turn the talk over to you.
Well, thank you. I really appreciate the opportunity to join this webinar. I think the Lymphoma Research Foundation is doing a wonderful job, not only supporting researchers like us, physicians like us, doing research in the field of lymphoma, but also providing important educational and support services to our patients. So the topic for today is understanding the diagnostic and biomarker testing for lymphoma and chronic lymphocytic leukemia. These are my disclosures. So I want to start by discussing with you the outline for today's webinar. You might have seen this on the Lymphoma Research Foundation website. We'll start with the introduction on the topic, and in particular, talking about lymphoma. We will then talk about what is biomarker testing. We will then talk about how is biomarker testing useful in lymphoma and chronic lymphocytic leukemia. And then we will move on to the how are lymphomas and CLL diagnosed. We will then discuss patient access. How do you access these biomarkers? And at the end, we'll discuss what are the latest advances in testing. And I think we're going to have a good amount of time for discussion and potential questions from the audience. So lymphoma and CLL, which means chronic lymphocytic leukemia, are a very heterogeneous group of blood cancers that are derived from the lymphocytes. The lymphocytes in our body are part of the immune system, and they are the ones that produce, for example, antibodies. They are called B cell, or the one that kill cells that are infected by a virus, for example, T cells that kill a viral infected a cell, or they can also be the one that kill tumor cells. So what happened to these cells, these lymphocytes, when they become a lymphoma or chronic lymphocytic leukemia, which is a form of lymphoma that is predominantly in the peripheral blood? Well, what happened is that these cells of the immune system, they accumulate mutation in their DNA, which leads to their proliferation that is not controlled. And so that leads to the proliferation of these lymphocytes that are now neoplastic, they are now malignant in the blood, but also in the lymphatic tissues. For example, the lymph nodes, the spleen, or even in tissues like the gastrointestinal tract, in the skin, in the lung, or as I mentioned, in the blood. And in particular, leukemia means when the lymphoma, the disease is spread and is present in the peripheral blood. And you can see in this schema potential site for lymphoma, the tonsils, the lymph nodes, and the spleen, as I mentioned here, and of course also in the bones. So a question that we are asked all the time where we diagnose a new case of lymphoma or chronic lymphocytic leukemia is, doctor, why did I get this disease? And the reality is that in the vast majority of cases, we're not able to tell specifically what were the exact factors that led to diagnosis of lymphoma. There are certainly contributing factors. For example, there are genetics factors that we can see, but they are not really clear. There are some families that have a higher incidence of CLL or lymphoma, but it's very difficult to point out to clearly genetic lesion that lead to that. There are certainly some environmental factors, for example, benzene, pesticides, that can lead to the incidence of lymphoma. And exposure to previous radiation can be a cause of lymphoma. We have also over the years understood that when a patient has an autoimmune disease or when a patient has an immunodeficiency, for example, HIV or AIDS, or a patient that received, for example, an organ transplant, and so he or she have to receive immunosuppressant, in those patients, given the sort of inhibition of the immune system, some of the lymphoma cells can rise, and so that's a risk factor. And lastly, of interest, I think in some cases, there are lymphomas that have been directly correlated to viruses. For example, the HTLV1 that can generate a form of T-cell leukemia, EBV that is present in some form of lymphoma, Helicobacter pylori, and the virus of hepatitis C. That doesn't mean that all the patients that have that virus will develop lymphoma. I just want to be very clear. But some of these lymphoma, we find the virus associated with the occurrence. But we still don't know why some patients do get the lymphoma and some other don't. So signs and symptoms of lymphoma are not super specific, are quite general. For example, you can have fevers. You can have a lot of night sweats. One important symptom, not just for lymphoma, but in general for cancer, is losing weight unintentionally, especially in a significant amount. Of course, an important sign of lymphoma is the presence of lymphadenopathy. So lymph nodes that are becoming bigger and bigger without a sign of infection. And typically they are not the lymph nodes that can generate pain like in infection, but these are lymph nodes that are continues to grow, are sort of stiff. And so those are the ones that are more concerning. Fatigue, in some case, you can have rash with itching, and in general, organ dysfunction. But in many cases, for example, I want to give you the example of chronic lymphocytic leukemia. In about a quarter of the patients, we do not have any symptoms. And the diagnosis of CLL is made just by looking at the peripheral blood for other reasons and see a high level of lymphocytes. And with further analysis, we can define that as chronic lymphocytic leukemia. So is this a common disease, lymphoma, lymphocytic leukemia? I'm going to show you the data here for non-Hodgkin lymphoma and later also for chronic lymphocytic leukemia. Well, you can see that in male, they account for about 5% of the cancer diagnosis here. If you look at the ranking, is in 7th position. And this is also similar for the females. These are the new cases in the US. I mean, the good news is that, as you can see here, when we're looking at the death, they're actually not number 7, but they go down in the ranking because we have quite effective treatment for this type of disease. So saying lymphoma or lymphoid leukemia is a very broad term. There are many different subtypes, and you can see here that the most common ones are the B-cell derived lymphomas. And I included here also multiple myeloma, which we're not going to focus today, but is a quite common disease that is derived by not the lymphocytes, by the plasma cells. And you can see here about 100,000, if we exclude myeloma, are B-cell lymphoma. And within that, the majority are the so-called non-Hodgkin lymphoma, 75,000 a year, and chronic lymphocytic leukemia is about 20,000. We have also other types of lymphoma that are more rare. For example, T-cell and NK cell neoplasm, 10,000 cases a year, or Hodgkin lymphoma, 8,000 cases a year. Again, they're more rare, but certainly we do take care of these patients in our institutions. And again, I mentioned in this slide non-Hodgkin lymphoma, which again, within this name, there are so many different subsets. You can see here that we have the most common form of lymphoma that is called diffuse large B-cell lymphoma. Is an aggressive lymphoma. It is about 30% of the cases. Then the second most common one is follicular lymphoma. And then we have a lot of other subsets, for example, mantle cell lymphoma, this is CLL, etc., that are a smaller percentage of the pie. So getting to the topic of today's discussion, what are biomarkers and what is biomarker testing? So biomarker testing is a way of looking for specific substances or changing in the body that give us the information about potentially the presence of a lymphoma. And we call these substances biomarkers, and we can find them in many different tissues, typically from the blood, but also from biopsies or other body fluid. There are many types of biomarker. For example, here I divided them based on their nature. So there are genetic markers. So this is related to the DNA. So specific mutations or let's say chromosomal aberration that we find in the DNA, they might be allowing us to diagnose a specific type of lymphoma, but also giving us information about the outcome. one example that I pointed here is that the mutation of p53, for example, in chronic lymphocytic leukemia, is associated with a poor outcome and a lack of response to standard chemoimmunotherapy that used to be the standard. And so we have new therapy for this, but obviously it's important to know if the patient has this lesion. There are protein biomarkers. So these are not from the DNA, these are actual proteins. And for example, there are many, but one that I want to point out, one of the markers that we use to diagnose lymphoma, together with all the other tests that I'm going to show you in a second, is the presence of high levels of LDH in the serums of patients. And so that typically is a marker of the proliferation of the lymphoma cells that leads to the release of LDH in the blood, and so we can measure it. And finally, we talk about DNA, protein, but also metabolites are potentially used to diagnose and monitoring for lymphoma. For example, I would say one of the markers that is used is radioactive glucose that we give to patient, and then we do a PET scan that allows us to understand where the tumor is located within the body, because the tumor will pick up the radioactive glucose. So this is just our examples of different types of biomarkers that are currently used in the clinical setting. And so we have these biomarkers. How can we use them? Well, they're used at different stages of the patient journey. They're used at diagnosis. As I mentioned, we can use some of these biomarkers, for example, from tissues or from the DNA, to help us determine the clear histology, the clear subset of lymphoma that we will be dealing with. It's really essential to use them because sometimes two types of lymphoma look very similar just at the microscopy analysis. But then when we use the biomarkers, we're able to say, oh, this is this type, this other one is this other type. As I mentioned earlier with p53 as a DNA biomarker, we can also use them to predict response to treatment. And so these are called prognostic biomarkers. And I would say that biomarkers are becoming more and more important to track response to therapy and also monitoring for potential relapse. And so there are different ones. We will be talking about a few of them that are used to try to monitor the disease. And lastly, when we have to decide what type of treatment do we want to give to a certain patient, if that treatment is specific to a specific antigen, we often look for that antigen in the tumor biopsies, for example, to make sure that that patient would respond to treatment. In other words, if you want to use an antibody against PD-1 or a CAR T cell is a type of immunotherapy, we'll tell you later about it, against CD19, you might want to make sure that those markers, those biomarkers, are expressed in the biopsy of your patient. And so how do we diagnose lymphoma in CLL? Well, typically, a biopsy is required. So this means that we need to do the imaging, for example, the PET scan or the CAT scan, or both of them more commonly, identify where the disease is, and then using different strategies, can be with a needle and take a core, or can be through an excisional biopsy that is preferred, to take a piece of the tissue and analyze that tissue. For chronic lymphocytic leukemia, sometimes it's enough just to look at the peripheral blood, although in many cases we also do biopsy to confirm the diagnosis. And so once the tissue is taken from the operating room or from the radiology room, it goes through different processes, as you can see here. That all these steps are done in the pathology department. And so they are put it into blocks of paraffin and then very thin slices are cut and they're put on top of a slide. And at that point, we do the so-called staining that you use for imaging that goes through different steps, as you can see here, but the final results is that we can visualize with different colors different biomarkers. You can see an example here. This is the slide. We have the tissue here with all the tumor cells, and then we use this is the sort of arrow. The blue arrow is the biomarker, and we use antibodies. Sometimes use a couple of antibodies to visualize them, to bind to the marker, and then we're going to get images like this one, and I'm going to show you in a second other pictures that allow us to understand if that marker is present and is present in what type of cells. A few examples. So to the naked eyes, maybe there are similarities between these two pieces of lymph node, but the reality that is even by looking at the morphology, they are different to the expert eye. This is a diffuse large B-cell lymphoma, and as I mentioned, is the most common type of lymphoma. This is instead a Hodgkin lymphoma, so non-Hodgkin Hodgkin lymphoma. And you can see that we can visualize the cells without any particular marker, but we then can use biomarkers that are listed here. CD30, CD15, they are typically positive in Hodgkin. CD20 is positive in non-Hodgkin. And if we diagnose a non-Hodgkin lymphoma, in order to get more information about the actual nature of this lymphoma, we can do additional biomarkers. And again, I don't want to go too much in details because obviously, as you may imagine, there are hundreds of these different biomarkers, and I'm going to show you in a second some of the ones that we use to diagnose patients. But these ones, CD10, BCL6, and MAN1, we use them to identify different subsets of diffuse large B-cell lymphoma. Why do we that routinely in the clinic? Well, because we know that the non-GCB, for example, subset of diffuse large B-cell lymphoma typically has a more aggressive behavior. And so we want to, we might treat them differently in some cases in the presence of trials, or we might to have a close eyes on those patients. Another technique that we use to study biomarkers is called flow cytometry. And why it's called flow cytometry is because we measure cells. Cyto stands for cell. We measure cell in a machine that runs through a flow. And the flow is shown here. We take the cells. These are single cells from the tumor. We stain them to look for the biomarker. Again, this is the biomarker in blue. And then these cells, they go through a very complex system of tubing that basically, thanks to the use of lasers, they are able to identify if this specific cell is positive or not for a biomarker. So as you can see here, this cell is not positive. This cell is positive. We see that there is we call them fluorophores that lights up, and then we see fluorescence, and then we're able to say, okay, this is a positive case. And I mentioned that by using what I showed you earlier, the pathology slides, we call that immunohistochemistry, or using flow cytometry, we are able to say, this is a lymphoma of this subset characterized by the following biomarkers, and given the presence of these other ones, we can predict the prognosis. Let me give you an example. Over here, by looking at all these markers, we can go from just saying this is a clonal process, so this is a tumor, because we can say that all the cells are derived from the same initial cell, so it's a clonal expansion of the same cell. But we can use all these markers that you can see listed here, and I don't want to go too much in details, but we can say, okay, this is CLL, chronic lymphocytic leukemia, or this is mantle cell lymphoma. This is Burkitt. Is this hairy cell leukemia? Is this something else? So we can use all these markers to identify the right diagnosis for each patient. So I show you immunohistochemistry done in tissues. I show you flow cytometry. But I would say for some of them in the last decades, from some other tests like molecular testing, in the last few years, we're now getting very sophisticated. So not only we can look for the presence of specific proteins, as I mentioned, for example, CD20 for non-Hodgkin lymphoma, but we can now look at the chromosomes. See that these are the chromosomes. Each one of them is a chromosome, right? And we can look how many there are in there, because sometimes they lose or gain chromosomes. We look at the if there are fusions, if there are translocations. And so we're able to look at the chromosomes and do the so-called cytogenetics. And cytogenetics really help us understanding the prognosis and even the nature of some of these lymphomas. Another technique that sort of helps in doing this and actually gets additional information is the fluorescence in situ hybridization, and we call it FISH. And FISH actually is the one that allows you to identify translocation, because they have different probes. And you can see in this case, one probe binds here, the other probe binds here in this, but in one set of the chromosomes, they bind together, and you can see the yellow signal. So that means that those two portions, this one and this one, that in one half of the cell, the chromosomes is okay, in the other half is actually fused together. So there is likely a fusion gene, a translocation that happened. And so again, you can look at the karyotype here, the cytogenetics. Here you can get more information about exactly what type of aberration are happening at the cytogenetic level. Lastly, I think this is something that is not done in, let's say it's not maybe routinely done in every single patient, but it's certainly been more and more commonly done in patient with relapsed refractory disease, is to do molecular testing. I mean, some molecular testing is also done at diagnosis, but these sort of panels, you can see there are hundreds of genes here. This is the example of the so-called PEN sequencing panel. That is a panel that includes a lot of mutations that are common in cancer. And so now we are using this more and more, because we like to get more into details of what are the potential mutations in these patients. And in some cases, this really helps us giving a better diagnosis, a more precise diagnosis. And in some other cases, help us potentially finding therapeutic targets. So I told you about the biomarkers and what we do on the biopsies and in the peripheral blood. But obviously, when you have to diagnose a patient, we do a lot of different testing. And I just want to make it sure that this audience is aware. We do a lot of other tests and a lot of other activities to fully understand the status of this disease. History, of course, very important. As I mentioned, exposure to risk factor, familiarity, comorbidities, and so on are essential. Physical examination still is a mainstay for a newly diagnosed lymphoma. Then I mentioned we do general blood tests. Again, I would like to stress some of the biomarkers that you can see here. For example, I mentioned the LDH. ESR is a marker of inflammation, and beta-2 microglobulin also can have some prognostic implications. And then we do imaging study in the radiology department. CT scan, PET scan are essential for the vast majority of these patients. And bone marrow biopsy is done for a set of patients, not for all of them, but also help understanding if there is disease in the bone marrow. So inside the bones, there can be disease. And so we take a sample from the bone. And then based on the results of the CT scan, we might want to look at the gastrointestinal tract or specific sites, for example, the lumbar puncture, will basically allow us to get the cerebrospinal fluid, which is around the it's basically surrounding our spine, and is basically can be infiltrated by lymphoma or leukemic cells. I mentioned when we're using biomarkers, we can also use biomarkers that allow us to do better imaging. And so in this case, for example, you can see a CT scan over here. This is, you can imagine, this is sort of like a slice of the chest of the patient, and you're looking at it by, if you, it's like you were looking from the feet. So the head will be behind and you're looking from the feet. And you can see, for example, there are masses here in the mediastinum. This is a pleural effusion. So you can get a lot of information about what's happening to this patient. And you can see here, this is the PET scan. So the PET scan, which is overlaid on the CT scan, is a completely different type of imaging. You can see that everything that glows, it's considered tumor. And the reason why we see that glowing is because the tumor is very proliferative. And so they need to get a lot of glucose, which we injected into the patient and is radioactive. So we're going to see the glucose picked up preferentially by the tumor as compared to the normal tissue. But the good news, again, as I mentioned, we have a lot of effective treatments. And so as you can see here, even in this patient with pretty disseminated disease, as you can see here, with, as I mentioned, disease in the chest. These are the lymph nodes of the neck. You can see some disease here in the tonsils, etc. After treatment, you can see that the disease is clear. This is just the heart that is supposed to be this color because it's picking up a lot of energy, obviously, a lot of glucose, and the brain is also positive typically. And these are the kidneys that are secreting the radioactive glucose. And this is the gallbladder with the, so those are not tumor sites. So thanks to these biomarkers and thanks to the list of tests that I show you, we're able to define what is the stage of the lymphoma. This specific one is for lymphoma. We have slightly different staging for chronic lymphocytic leukemia. So we call stage 1 when only one single lymphnodal area. We get stage 2 when there are 2 sites, let's say the neck and the axilla, but they're above or below the diaphragm. So they could also be here, but as long as they're on the same side, that's stage 2. When you have 2 or more locations, but they are on both sides of the diaphragm, well, then it's called stage 3. And then stage 4 is then when the disease is above and below the diaphragm and is also involving other sites, for example, the liver, the spleen, and the bones, and so on. So I mentioned so far the biomarkers that we use for monitoring, that we use to diagnose a patient. But there are also, as I mentioned, biomarkers that are used to monitor response, right? And so obviously the clinical exam is not really a biomarker per se, but we do that in patient. We check the lymph nodes and we make sure that they're going away. The metabolic biomarker that we use is the PET scan, as you can see here. And there are also blood tests, as I mentioned, trending the LDH or just the counts, the lymphocyte counts in the blood. It's a good biomarker to see if the disease is responding. And obviously, when you use this biomarker, you can do it from the blood. You can also do that from biopsies. If we have the suspect of relapse, you will take another biopsy and look at biomarkers there. Or you can use also flow cytometry. If you want to go deeper and look specifically at certain cells, you can use flow cytometry that I mentioned you earlier. And I'm going to talk in a second about what is MRD, or minimal residual disease, that I mentioned here. Let me talk about minimal residual disease, MRD. So this is a type of biomarker that is becoming more and more used in the clinical setting. For example, is FDA approved for chronic lymphocytic leukemia. And what is the key concept is that we do all the tests that I showed you earlier. We can do PET scan, we can do flow cytometry, we can do a lot of things. But there is an intrinsic limitation of sensitivity of the technique that we use that can detect different levels of disease, right? For example, if I do a clinical exam to the patient, as you can see here, I might be able to see the tip of the iceberg, right? I can check the lymph nodes, and I can feel it and say, okay, there is disease there. But when the lymph nodes start to shrink after treatment, I might not feel it, but it might still be there. And so you get to different levels of, for example, this is the example of leukemia, but you can say the same thing for lymphoma. As the number of cancer cell decreases, you can see of a different log, so significantly, we might reach a level where we don't see the disease, for example, here, but there is still some minimum disease left. And so we call MRD, or measurable residual disease, or minimal residual disease, is the same thing. When you use very sensitive techniques to look at very little amounts of cells, for example, one cell every 10,000, one cell every 100,000, 1 million cells. What are these techniques? These techniques are shown here. Let me show you in a second. These techniques are shown here. And they are the following, as you can see here. These are, for example, if this is like the tip of the iceberg. I gave the example of the clinical exam, but you can also just simple use of a microscope. In this case, these are the bad guys. These are the leukemic cells. But then you can get into the multicolor flow cytometry. And so now you're getting more in this type of sensitivity. So you're able to detect one cell out of 1,000, 10,000 cells. Then you can get into molecular technique, real-time PCR, and next-generation sequencing that now allow us to go very deep, up to 10 to the 6 to the minus 6, which means I'm able to detect one single cancer cell out of 1 million cells that might be in the blood. So we're getting now to the level that we can really get deeper and deeper in measuring how much disease is left for each patient. And so this is starting to change, obviously, what is the way we monitor patients, right? Because you can imagine before having this technology, this is an example of mantle cell lymphoma, but you can apply this to many other type of lymphoma, and in particular, chronic lymphocytic leukemia. You would do your treatment, but you would be able to see the disease only when the disease gets to a pretty high level. Instead, now with the MRD, you might be able to see an initial bump here of the disease thanks to the MRD, and already do early intervention. So thanks to this biomarker, you might say, look, the disease is coming back. We can see a trend coming back, and so we can do something early, so that we don't need to get to the point where you have big lymph nodes, you have symptoms and other signs of disease, but we can start the treatment right away. And so clearly, many of you might have the question, how can I access to this sophisticated testing? Well, the good news is that the vast majority of the one that I mentioned are recommended by the guidelines and also are FDA approved. So these are standard biomarkers that most cancer centers would perform. I would say that in general, for diseases like cancer, and in particular, I would say lymphoma, where there are so many different therapies, so many different subsets, it's always a good idea to have to refer to a tertiary center, or at least to have a second opinion from a tertiary center that really sees a lot of patients with that specific disease, especially if it's a rare disease. For example, T-cell lymphoma or other type of lymphomas. There are trials. You will be approached, for the ones of you that are patients, you will be approached by clinical coordinators that would ask you if you want to become a part of a research study and donate some of your blood or part of the biopsy that is taken. And that, while it might not directly benefit you, it might really help the research to move forward and to identify novel biomarkers that can be used. And I'm showing you clinicaltrials.gov is a website that collects all the trials, not only the biomarker trials, obviously, but also the Lymphoma Research Foundation, as mentioned in the introduction. They have resources that can help you figure out if there are biomarker studies in the institution where the patient is treated. And as I mentioned, it's a good idea to join these programs because your tissue or your blood will be biobanked and will be used to make discoveries that potentially will lead to advancements in the field. Let me tell you about a little bit of the latest advancements. I would say that the minimal residual disease, especially by flow cytometry, is pretty established for certain form of leukemia. The molecular one that I mentioned that goes very deep is approved for chronic lymphocytic leukemia. It's called clonoSEQ. But they are expanding, right? So it's certainly a latest adoption, but has been around for decades. I would say that one of the big breakthrough in the therapy of lymphoma and chronic lymphocytic leukemia is chimeric antigen receptor T-cell immunotherapy. This is a topic that is very dear to me because I've been working on this for the last 12 years here at the University of Pennsylvania. We were the first center to bring a product to the FDA approval, and so we have a lot of experience on using this new therapy. And how does CAR T-cell, chimeric antigen receptor T-cell immunotherapies, abbreviated to CAR T-cell, work? Well, patients with cancer are receiving leukapheresis. We collect the white blood cells from the blood, and these white blood cells, in particular the T cells, are engineered so that they express a CAR on the surface. This is a special receptor that will allow this T cell to kill the cancer cell. And so when we infuse them back, they're going to go around the body, find the tumor cell, and kill those cells. And so why I'm talking about this? Well, I'm talking about this because we have now 6 FDA-approved CAR T-cell therapy, and all of them are for B-cell malignancies and multiple myeloma. So the vast majority of the lymphoma that I've been talking about do have a CAR T-cell product approved that can be used in the clinic. And the results are pretty spectacular. You can see in just 1 month, a patient with all this disease, this is the armpit, this is the neck. You can see a lot of disease completely gone away, only 1 month. But today we're talking about biomarkers, right? So why I'm talking to you about this? Well, I'm talking to you about this because obviously here we're using a live cell product. So this is an autologous, so it's taken from the patient, modified, shipped back to the patient. And these are live cells, so they enter the body and then they can go around and start proliferating. And so we do need biomarkers to know if these cells are expanding, are doing their job. And what you can see here, this was a paper published by the group here at Penn, looking at CAR T-cell therapy in chronic lymphocytic leukemia. You can see, for example, by using different techniques, both flow cytometry that I mentioned earlier, and also molecular techniques. In red, you can see molecular, the PCR, and in blue, the flow cytometry. You can see that these cells, upon infusion, they expand in the peripheral blood, then they clear the tumor, so they go down. You can see this other blue line. This one is the leukemia going away. But they persist. So we can take blood and measure these engineered CAR T cell, and we can find them almost at 10 years after the initial infusion. So a very important biomarker to know if our therapy is working in the patient. And why we're using biomarker also to monitor the patient. I want to show you 3 examples. So these are 3 biopsies. Okay, each line is a different patient. And this was taken after CAR T cell therapy. And you can see that if you look just at the microscope with a basic staining, it's called H&E, hematocillin and eosine. It's just a standard just to visualize the nuclei of the cells. You can see that they look pretty similar. So if you just do the biopsy, you would say, well, they relapsed, but I really don't know why. You know that they are B cells, which is a tumor cell, because they express this marker called 79. But now you can start to see that some of the biomarkers are being lost. This patient doesn't have CD20, but more interestingly, this patient doesn't have CD19. Why I'm saying that? I'm saying that because CD19 is the target that is recognized by the CAR T cell, so that immunotherapy that I was telling you. And so in this case, we can say, look, this patient relapsed because it lost the expression of CD19. Therefore, it becomes invisible to CAR. And so we're going to have to choose a different therapy that does not target CD19. And let me conclude by telling you about newest biomarkers that have been studied. One of them is called circulating tumor or cell-free DNA. So these are pieces of DNA that are released by the tumors. As you can see here, these are the little pieces of DNA. They are released in the circulation, and they can be detected using molecular techniques. And so obviously, this is a very exciting technology because they are also called them liquid biopsies. What does it mean? You just take a sample of peripheral blood, and you might be able to say what type of tumor, if the tumor is coming back, and so on. It's still a research tool, but now it's being more and more applied in both solid and hematological cancers. And so I would say that we have a lot of techniques that are coming up. We have, as I mentioned, the circulating DNA. We have more deeper sequencing. I show you the panel, 100 genes. Now we're looking at 500 genes that we're studying. But obviously, without changing the technique, our research might lead to identify other markers for toxicity, for response, and so on. And so there would be new prognostic markers, new diagnostic markers, and new monitoring markers. And I think I will conclude here with these latest advances. Again, a big thank to the Lymphoma Research Foundation for the opportunity to present this topic. And I think we have time for a few questions.
Great. Thank you so much, Dr. Ruella. Would it be helpful for me to read these from the Q&A box?
I can take a look at them. I see
Okay.
that some of them are pretty long, so probably will be more efficient to go through them. I see that some of the questions are specific for certain patients, and they ask for advice. Of course, I'm always happy to help, but it would be hard for me to give it, my informed opinion without really taking a broader look at the test. But I'm gonna go with the first from an anonymous attendee. He's asking about a patient with diffuse large B-cell lymphoma that has completed 3 lines of therapy. over the past 3 years and is currently in remission. He received a very good standard therapy first line called Pola-R-CHP, and then receive actually second line CAR T-cell therapy. I'm glad I mentioned that, against CD19, and then also a bispecific antibody for CD20. So the patient likely relapsed a few times. And then during the remission, they have used clonoSEQ to detect the relapse, and this will allowing for early detection. And biopsy was done only an initial diagnosis. So the question is, if the relapse occurs, should we wait for disease progression to enable a new biopsy to determine if the disease is mutated, with new biomarkers to guide therapy, and what new targets look promising in clinical trials? So these are very good questions, and I think the person who asked this question is exactly right. So with clonoSEQ, you're able to detect if that specific clone, that's why it's called clonoSEQ, that the specific barcode is coming back, but it would not allow you to understand new features that might have changed in the patient. And so that's why still for the LBCL, we're sort of, we are, in some patients we use it, but it's still sort of a exploratory technique. I would say that when the patient relapses, is always a good strategy to take a biopsy, especially if the relapse happens after years, because we do see changes that might lead to different type of approaches. There are, for example, follicular lymphomas that then become aggressive lymphomas, and so you need the biopsy in order to determine that. And in addition to that, with some of the new molecular testing, in some cases they're still not super common, but in some cases you might be able to find targets that for which we have agents that can be specifically effective in that. And so what new targets look promising in clinical trials? I think targets is different than biomarkers. I guess in this question, targets are the one that you can actually target with drugs. And so I think that we're in a stage that I would say, rather than necessarily new targets, we're developing new techniques to hit those targets. For example, CAR T-cell bispecific antibodies, antibody-drug conjugates. And an exciting part of this advancement is the fact that they can be combined. So for example, here at Penn, we have a couple of trials where we're combining CAR T-cell with bispecific antibody. So you're hitting CAR T-cell with CAR T-cell CD19, and with bispecific, you're hitting CD20. Another patient case that has been reported about a marginal cell lymphoma with positive biomarkers that are characteristic for a marginal zone lymphoma. He received 4 infusions of rituximab, which is an anti-CD20 antibody, which is a standard therapy for this disease. That is a slow-growing, non-aggressive disease. And I would say the question is, does Rituxan impact all of the observed positive markers? It's a very good question. And I think I mentioned the issue of hitting a specific target that can lead to the loss of that target. We find that commonly now in CAR T-cell therapy. We're starting to see that with bispecific antibodies. It is a little bit less common with the use of rituximab. So I would say that probably 4 infusions of rituximab are not going to impact CD20 dramatically, and they are not expected to impact the other biomarker, PAX5, BCL2, CD138, K67 that is listed there. Of course, they're going to impact them because they're going to get rid of the tumor, and so we're not going to see those markers anymore in the tumor site. But it shouldn't. Typically, rituximab in marginal zone lymphoma doesn't lead to. It's happened, but it's not very common to lose CD20. The next question is, why do you call lymphoma CLL blood cancer? No, I mean, these are blood cancer. Yeah, I think there is a misunderstanding here. Yeah, they're called blood cancer because they're derived from cells that are in the peripheral blood. So even if you find them in the lymph nodes, they are derived from the blood, from the hematopoietic system. How can we tell the difference, the different blood B cell exposed to a pesticide and classic CLL? That's a very difficult question. So it's very hard to connect exposure to a pesticide and lymphoma. There's some lymphomas that are more common upon exposure to pesticides, but there is not a clear biomarker for that. And would treatment vary between the two? I would say it wouldn't vary due to the pesticide exposure, but it might vary based on the biomarkers that I show you. So the cytogenetics, the molecular data, the flow cytometry, and so on. And sometimes they're different when there is exposure to a toxic agent. Some people say, Dr. L, thanks for your great presentation. Thank you for attending. Is ctDNA available for T-cell lymphoma? It's not available in the routine clinical practice, but there are studies that show that can be used, and so it would need to be within a research program to receive ctDNA for T-cell lymphoma. We do use flow cytometry, which is able to identify without very good sensitivity the cells, but ctDNA, no, it's not done yet in the routine practice. Dr. Perez asked another question about the distribution yes, the citation, it's talking about the distribution of common non-Hodgkin lymphoma subtypes. Is asking if the statistics have changed over the last years. They have slightly changed. Some of them are more common, some of them are less common. I would say overall, they are pretty stable. The numbers that I've shown you actually are updated as of this morning when I updated my presentation. So the incidence was is from the latest statistics that are available. ctDNA is approved for clinical trials. Yes, it is in clinical trials. That's correct. Why might a patient in remission with follicular lymphoma have elevated LDH for 10 years? Again, this is a difficult question for me to answer without not knowing all the details about the patient. Typically, if we see the LDH increasing, we would be worried about a disease recurrent. But obviously, if this has been for 10 years, there might be other causes for LDH elevation. LDH elevation is not only associated with lymphoma, but can be present, for example, in other diseases like hemolytic anemia, for example, and other diseases. Another question that we have here, and I'm not sure if we're going to be able to go through all of them, and my apologies for that. It's there really a lot. I would probably select a couple of them. One question is about if you have Hodgkin lymphoma and you do chemo, does this alter your DNA? If so, is that DNA then passed on to children you have afterwards and does give them a greater risk for cancer? It's a very important and I think a very sensitive topic. Chemotherapy per se can lead to secondary cancers. That for sure. But so from that regard, it can lead to alteration in your DNA that might cause secondary cancer in a very small percentage of cases. However, this again, it might change in case of a man or a woman. If fertility is preserved, typically the cells are particularly protected for, so the cells in the women and cells in the man, the spermatozoa and the ovules are protected because they don't actively replicate, and so typically we don't see mutation accumulating there. And I think the last question that we can take for today, I'm gonna for example, a patient is asking if you and your brother have CLL with different markers, are they considered related? I mean, of course, given that it's a common blood cancer, but the chances that two brothers have CLL is very rare. And as I mentioned at the beginning, we do have cases of familiarity for CLL. I would say that it's difficult to understand if they are related. I would think that with the new biomarkers that we are developing, looking at specific mutations and looking, I think in this case, more broadly at the whole DNA, is called whole exome sequencing, you might get information that tells you if there is some specific predisposition that can lead to that. I think we are running out of time, and really my apologies for the many of you that have joined and have been asking questions. I will discuss with the Lymphoma Research Foundation if there is a way perhaps to tackle some of those questions or maybe all of those questions offline.
Thank you so much, Dr. Well. Yeah, we'll come up with a way. Maybe we can answer some of the remaining key questions in email, some of the participants. We can pick some of those out, which would be great. But thank you so much for joining us on today's webinar. This was wonderful. And for everyone who was watching, please remember that this is recorded and it'll be sent to you following the program, hopefully tomorrow or the next day. And please remember, if you have any additional questions, you reach out to our helpline at 800-500-9976. And with that, I'd like to thank you all again, especially Dr. Ruella, and have a wonderful day.
Bye-bye. Thank you.
Bye. Thank you.